There's been a great deal written about underutilization of PCI and, for that matter, other medical therapies in certain demographic groups such as minorities and women. What we wanted to do in this study was see what the predictors were of potentially inappropriate use of percutaneous coronary intervention, but at least in terms of AUC criteria, did certain demographic predictors allow us to determine who was at higher or lower likelihood of getting an inappropriate PCI. This study was based on the NCDR Cath PCI registry, which has evolved into an incredible resource for research and study of utilization patterns of various technologies in cardiology. We identified 200,000 plus patients who underwent non-acute percutaneous coronary interventions between July of 2009 and March of 2011. So it's a very large sample of patients. And of that 200,000 plus, approximately 12% of the patients, around 25,000 or so, had PCIs that, as best one could tell from the documentation, would be classified as inappropriate per the AUC criteria. What we then did was determine what are the predictors of this inappropriate PCI. What we found, perhaps some would view as surprising, was that the major predictors in terms of patient characteristics of a patient getting an inappropriate PCI were being male and being white. So it's, I think, quite interesting. There's been a lot written about underutilization of PCI and CABG in women and in minorities, and that body of research still stands, and we still need to do what we can to improve appropriate use of care in those groups. But what we found was, with respect to inappropriate PCI, being male and being white increased the likelihood of that significantly. Similar to those patient characteristics, there were also other characteristics that seemed to predict inappropriate PCI, in particular having private insurance as opposed to having no insurance or public insurance or Medicare. So being privately insured was associated with a higher likelihood of having an inappropriate PCI. For those physicians that are performing PCI, now specifically we're talking about elective PCI, I would advise do whatever you can to really document the thought process, why that PCI was necessary, and why, even if it doesn't seem to meet the letter of the law per the AUC criteria, there were extenuating circumstances that made it the right thing to do clinically. I think that sort of documentation, while that can be painful and add to the length of the workday, is important, I think, by trying to focus on the actual clinical history and less so those demographic factors which might influence either in ways that are helpful or not helpful in deciding whether a patient should undergo a procedure. That might remove some of our unconscious biases that may come into play in daily clinical life. The bottom line here is that we did see that there was relative overutilization of PCI in certain demographic groups, and perhaps moving forward we can just try to fine-tune which procedures we're doing in which patients and try to take out subjective or sort of more subjective assessments about, oh, this patient's gender or this patient's ethnicity should affect my thinking, because most of the time for coronary artery disease, it probably shouldn't.